if we can. And the first question I'd like to ask everybody, actually the same question, is for the clients, for the people that you serve, what is the biggest barrier, what is the biggest obstacle to accessing, receiving those services? And you can talk about prevention or care or both. Nesreen?
So I think one of the main challenges that face key populations in the MENA region are human rights issues, anything related to the human rights and the criminalization of same-sex, sex work, IV drug use. Those are unfortunately major barriers. In addition to the stigma within the healthcare system, the other levels of stigma and discrimination at the different other levels. But the main problem, I think, is related to human rights and health as a right. And specifically when we're talking, when same-sex is criminalized, it's impossible to get out and move freely and get your healthcare rights in terms of either treatment, prevention, testing, or anything. If you're afraid, if you're targeted, if you're a moving target, whether in Lebanon or in any other setting. And to me, this is the main issue. And any program that doesn't, any intervention we do or we can think of that does not really aim at changing that, whether it's the law, like the judge was saying, the laws need to change because we're losing people while this is, and we need to really attack that. I mean, I'm surprised here that the funding for human rights within the programs is so little, and it should be at the core.
It's a good point. So both access and funding. Ellie, I wonder if you would speak from your organization's experience.
I have to agree with Nisreen on criminalization, but it also goes beyond that to discrimination. As our organization and coalition works in different MENA countries, not only in Lebanon, the issue of being discriminated against based on sexual orientation or gender identity and being denied services, denied treatment for men who have sex with men, and sub-key populations of the same population for gay and bisexual men who use drugs or are sex workers as well. So we have seen a lot of people who have been denied access to their medication, access to testing, or even being stigmatized for the fact that we are going to access the treatment. So I think stigma and discrimination is the most important factor, and that goes beyond laws or campaigns. It goes back to the educational system where we teach children about equality and acceptance rather than hatred and bigotry. Yeah.
All right. Thank you. Now we're going to hear from our friends from Malawi.
Her name is Judith Mtini. She's 26 years old. She's coming from Malawi. She is a peer educator.
Ife ngati ku Malawi ma female sex workers mavuto amene timakumana nawo makamaka asikana ngati ife oyendayenda kumenyedwa mwina kunyengedwa ulere osapasidwa ndalama.
So she says, as female sex workers in Malawi, some of the challenges that they face is gender-based violence. Most of the times their clients abuse them. They'll have sex with them and not pay them after providing the service.
Zinanso zimene timakumana nawo ngati chithandizo mzipatala ngati ife ma female sex workers amatisala kwambiri tikapita zipatala ngati zaboma.
So she says when accessing health services in government facilities, they also face stigma and discrimination from some of the healthcare providers. So these are some of the challenges that should share, which they experience as female sex workers in Malawi. Thank you.
Thank you for sharing that. Please.
Thank you. I'm Philip. I come from Uganda. in any program to succeed, there should always be meaningful involvement. Remember the slogan of us without us. Anything about us without us cannot succeed. So it's all about meaningful involvement of key populations, most especially having the peers as frontrunners as far as implementation of programming is concerned. But you find out that in most of the facilities or the settings that we are in, these undermined populations are left out, and they cannot have like someone to spearhead whatever the rights they want and whatever services. If I can speak on the side of prevention, it should be something to do with a peer-led model, whereby we should encourage the peers of the key populations to take lead, but this one does not happen. Then as far as retention is concerned and prevention, at the same time, lack of peers at facilities of key populations normally hinder. Because if you test someone and like you've linked, when it comes on issues of retention, it becomes a little bit complex, because as being a sensitive issue, we don't have peers on board to ensure that they follow up. Yet the other thing is that we have very many briefcase organizations now that are marauding around for donor funding. The funds they get do not benefit the intended beneficiaries. These funds are swindled, and at the end of the day, the original beneficiary is left out. This hinders the access of services to key populations.
So there's some structural issues with the funding.
Yes.
Yeah. All right. Please, Kazakhstan.
Меня зовут Оксана, я из Казахстана. Наши проблемы – это стигма, дискриминация в общей лечебной сети, не в центрах СПИД, а в общей лечебной сети. Это низкая правовая грамотность сообщества, чтобы защитить себя.
The main problem of our country, and my name is Oksana, I'm from Kazakhstan. So the main problem that we experience in Kazakhstan is stigma and discrimination in the public health system, and low awareness of key populations about their rights.
Это отсутствие программ снижения вреда в пенитенциарной системе.
Lack of programs of harm reduction in prison settings.
Отсутствие доступа к лечению, к антиретровирусной терапии у мигрантов.
No access to antiretroviral treatment for migrants.
И правовые вопросы, ну это скорее всего отсутствие мониторинга силами сообщества. Я вот поддерживаю коллегу с Уганды, то что ничего за нас без нас, и действительно очень, ну в основном голос сообщества не слышен, и в этом направлении только начинается работа.
And no peer-led monitoring of services by community itself, and that's why I support our colleague from Uganda, because nothing about us without us. That's the main slogan. Thank you.
Ну, я хочу сказать в защиту Казахстана, что у нас есть очень много, есть доступ к бесплатной терапии для людей, живущих с ВИЧ, есть доступ к программам снижения вреда, но единственная проблема – этот человек не получит эти услуги, если он официально не имеет правильных документов, не имеет гражданства. То есть если он лицо без гражданства или просто с утерянными документами, он не будет иметь доступа к этим услугам.
I want to say about Kazakhstan that we actually have harm reduction services, but you have to be a citizen of Kazakhstan to get access to that. That's why harm reduction services are not available for migrants. And we also have free access to antiretroviral therapy, but you also have to have a citizenship of Kazakhstan to get access to that.
We're having some issues with rights violations of migrants in my country too. Yep. Please.
Okay. So as a service provider, I think in South Africa it's critical, even though we have quite an enlightened constitution, that there is a patient charter. And people have to adhere to the patient charter. So I suppose the bottom line to addressing some of these issues is developing relationships. And I do believe that long-term relationships built on trust and honesty is really critical to address a lot of these issues. If you don't have a long-lasting relationship, you will not get patients adhering to therapy and addressing the issues and being able to address those issues. And one of the approaches that we've used a patient advocate model, very much like a peer, where these patient advocates are part from the community, they speak the language, they understand customs, and they are able to go out and provide adherence support, address the barriers to adherence, address stigma. They advocate for patients, and this has resulted in us being able to retain patients for over 5 years, about over 80% of patients remain in care, and their viral suppression being over 80%. It's a very good, cheap, sustainable model, and so it's really about taking services into the community, into the household. Thanks.
So Ashraf, you've actually opened the door to the next part of our conversation, which is I asked you all to talk about barriers for clients. I'd like now to move toward what Ashraf talked about, which is providers, the issues for providing services. That could be clinical services or peer services. And let's now try and get a little specific, because it's late in the day. So a little bit granular. If there was one thing you could do that you think would improve the provision of services for key populations in your setting, what would be the single most important thing to change? And then we'll go back this way.
Well, I would just advocate for access to the best treatments and vaccines, and certainly, well, what I mean is really getting those prices down, because that's one of the biggest barriers, is the cost of care. Thanks.
That's social and economic rights.
Ну, я бы, если бы действительно, учитывая наши вот барьеры в Казахстане, я бы все-таки организовала доступ мигрантов к лечению, к услугам, потому что они все равно часть нашего общества, которое будет влиять на общее здоровье.
If there is one thing I could do, I would make services available for migrants, because they are part of our society anyway.
Marvelous. Thank you for that.
Я как человек, представляющий сообщество людей, употребляющих наркотики, я, наверное, программу снижения вреда бы расширила, поддерживающую заместительную терапию расширила по всему Казахстану, и, конечно же, в пенитенциарной системе программы снижения вреда бы внедрили бы.
As a representative of a community of people who use drugs, I would increase the coverage of harm reduction programs in Kazakhstan, as well as coverage of antiretroviral therapy in Kazakhstan, and I would include antiretroviral therapy in prison settings, as well as harm reduction programs for drug users in prison settings.
Wonderful. Please.
Thank you. Having corruption and the embezzlement of funds as one of the issues, I would advocate for direct channeling of funds, donor funding, directly to the civil society organizations that are handling key populations programming. Thank you.
So moving the money directly to the service providers would
Yes.
have a big impact on provision of services. All right, well, it's an important insight. Please, from Malawi. And by services, we also mean peer services, of course. Please.
Ku Malawi lufuna kuti akhalako ma dropping center okwanira, komanso ngati machino ezera value load, anthu ama sex workers akapita kukayezesa ku dropping center zosatira zimachedwa kubwera kwambiri chifukwa choti machini ndi amodzi, ndezi zikamadzatuka zosatira zija mwina amakhala kuti ma female sex workers aja achokapo apita dera lina.
So she would love to see that there are more drop-in centers which are adequately funded, so that they adequately reach out to all the female sex workers. But also she would advocate for financing towards viral load machines, because they do, as female sex workers, the results for their viral load, they do take long to get their results, because there are few machines. Yeah, so she could also advocate for accessibility to that effect.
You know, that issue is a call that's come loud and clear across this conference, right? And you know, we're also excited about U equals U and which means, the movement, as many of you know, that undetectable means untransmissible, and people who are on successful therapy and who have non-detectable viral load are not infectious. But if you don't have access to viral load testing, you don't know if you're undetectable, right? And that remains an enormous issue. Please.
I'll have to reiterate the answer from before, because it goes both ways from service providers and from clients, is decriminalization. How do we expect people to come and access services when they're criminalized? Ahmed Ala in Egypt last September was put in solitary confinement. He was imprisoned for 80 days and tortured because he raised a rainbow flag. And we expect people to actually come and get tested to find out if they have HIV or not, and that's another stigma, another role. Also last year in Morocco, 2 teenage girls were almost sent to prison because they were kissing, 2 teenage girls. So I think decriminalization is one of the most important issues, to actually have people come to seek services, to get tested, and then to ask for their treatment and move on from there.
So decriminalization helps everybody.
Yeah.
Nazreen?
I would decriminalize and then make all services integrated and free, pretty much like what Ashraf was saying. It would help a lot if those sexual and reproductive health services were integrated with HIV treatment and prevention services, whether for testing, treatment, prevention, advice, awareness, peer, everything. All of those should be free everywhere for everybody, I think, because that would empower young women, this would empower gay men, this would empower trans women, this would empower everybody to accessing services, being able to using them while they're waiting. We're waiting for the decriminalization. I think starting with making them more accessible by making them free.
Right. So it's a real UHC, universal healthcare access approach.
And that's an issue because in our country, for example, people living with HIV are denied healthcare coverage by private insurers.
Right.
So that's yes. So that's it's not only for life insurance, but for health insurance.
So we have this wonderful panel of people, and we have about 15 minutes to go. I'd love to give everybody else the opportunity to ask questions, not just my questions. And if people would like to, please come to the mic. Let us know your name and your organization. And if your question is specific to one of these marvelous people, please let us know who your question is for. So would you like to, sir, if you'd like to go to the mic? You look like you were about to ask a question. Or madam, please.
Thank you all for this wonderful panel. We enjoyed it very much. My name is Mahan Muzaini. I'm from King Faisal Specialist Hospital from Riyadh, Saudi Arabia. My question is, I have 2 points. So Saudi Arabia and the Gulf region are considered to be high-income countries, and therefore we are excluded from global funds. I can understand this from different aspects of research related to cancer or whatever, because that can be covered from the government. But unfortunately, HIV and AIDS is very, still a stigma back home, and we're not getting enough funding, either for NGOs or for research. It's limited. Although that the country and the Arab countries are very generous, so they give, but toward other diseases, not HIV, unfortunately. I've been seeking doors for the past 4 years. And once they know that it's going for HIV related, they would not. So would that change the Global Fund's view and WHO? That's it.
Well, I don't know if Ralph is still in the audience. Oh, great. Ralph, maybe you want to take that one.
You would have many allies, of course, at the Secretariat, but unfortunately many of our donors simply do not believe that the Global Fund should be funding in countries that should be able to fund these services. Of course, it's an ethical quandary. It's a very difficult issue, particularly from a human rights perspective. But your advocacy should be directed to the donors because they are the ones that stand in the way of funding in high middle-income countries.
we often, talk about stigma in communities. We talk about stigma in healthcare settings. We don't so often talk about stigma among donors. But I think that's the issue you've really raised. Are there other questions from the audience? Please, sir, to the microphone.
Hi, my name is Dr. Qaid Saeed, and I represent National AIDS Control Program in Pakistan. I want to put a different perspective of the countries we are talking about. The countries which are basically where we have complex emergencies going on. We have wars. We have political instabilities like in Pakistan, Afghanistan, and maybe Central Asian states as well. And then we have, great say of religious leaders in our laws, in our implementation of the laws. Is it easy to decriminalize sex work, drug-injecting drug users in countries like Pakistan and Afghanistan? I don't think so. It's not easy. It's too difficult. And it's a very slow process. So I agree with Judge Kirby that in his country, Australia, and in America, which was a conservative society, and they changed with time, maybe 20 or 30 years. I don't see this happening in Pakistan and Afghanistan and countries like Central Asian states and even in Lebanon. It is a very slow process and it will take time. So what should we be doing with our key populations? How can we deliver them with our services that are needed? This is another perspective to be, we should all think about it, how to do it, because we are talking about countries where religious extremism is very high, where political instability is very high. In some of the countries, laws are very good, but the implementation is not there. So we have these multiple problems in our countries where epidemic is rising very fast, mainly driven by people who inject drugs, and then the criminal laws are highly against them. It is not easy to change them. It is not easy to implement them. That's the reality.
So I think the question really that the gentleman asked is let's just say that you can't change the laws. What can you do even in a non-supportive legal context? I don't know if anybody want to address that.
Just very quickly, I mean, my experience is when we were doing things illegally, like providing drugs for people, which we had to bring into the country, into South Africa illegally, we just did it. We did it underground. We camouflaged it. People knew where to get medication. So I think you almost have to go underground initially. But if you basically put your intention to be noble, and there you are, to put the patient first, and you want to save lives, I don't mind putting my head on a block for that. I'll stand in front of any judge when I'm trying to save somebody's life with what I know and the science that is backing me up. So, and we did that, and that's how things have changed. I don't know if anybody...
Please. Yes.
Я хотела бы, посоветовать и рекомендовать несколько вещей, что можно делать с сообществом. Мне кажется, самое главное – это взращивать лидеров, вкладываться в укрепление систем сообществ, чтобы люди росли, научить их документировать, нарушения прав человека. И вот я сама, мой личный опыт, я начинала сначала с клиента, потом аутрич-работник, потом социальный работник, потом специалист по адвокации, и вот росла. Но все это, с низов. И несколько лет в меня вкладывались семинары разные, тусовки, конференции. Это кругозор расширяет и уже, и людей, получается, взращивает. И многие, есть возможности для сообщества расти. И я думаю, люди потом возвращают это у себя на родине, пытаясь что-то изменить.
I think the main point is that in your country, you should focus on establishing the leaders of the community, like the leaders of drug use communities, the leaders of sex workers community, to train them to advocate for their rights, to make strengthening of community systems, and to train the members of community how they can document their rights, how they can protect their rights. Because I myself, I started right from the ground. I was a caseworker first, and then I was a client first, then I became a caseworker and advocacy an advocacy worker and a social worker, and now I attend conferences where I learn how I can protect our rights, how I can protect the rights of my clients. That's what you can do while your government is doing nothing.